Hello friends, conventionally we have been using locking plate constructs for fixation of distal femur fractures, especially those having articular involvement. But with the technological advances, we now have nails that can be used for fixation of these fractures because of the innovations in the design, which allows multiple screws placed through the terminal part of the nail, and those screws are actually getting engaged inside the nail holes. That means the nail holes here are having threads. So these screws are not functioning just like bolts which were used in conventional intramedullary nails. These screws are actually the part of nail fixed angle construct. That means they do not toggle inwards or outwards or do not angulate. So kind of fixed angle construct being provided by the intramedullary nail that is actually providing more stability. First, because of the intramedullary nature of this implant, which is definitely biomechanically more stable compared to the locking plate, and also because of the screw designs that I've told. So in this video, we'll be seeing what are the basic steps for fixation of distal femur fractures, especially the articular ones, using intramedullary nailing. So first of all, we should be aware why nails have better stability than the plates alone. So the axial stability, the rotational stability, and the bending stiffness is definitely better with the intramedullary nail because the nail is getting hold inside the intramedullary canal. Unlike the plate, which is going to cover only one particular surface, nail is going to uniformly distribute the stresses throughout the circumference of the intramedullary canal, that means whole of the diaphysis. Now, when to consider nailing in distal femur fractures? So simple bicondylar fractures, that means in which you have a single fracture line that is going through the condyles, those can be treated successfully with the intramedullary nailing. And those fractures which are extra-articular ones definitely can be treated with intramedullary nailing. So these fractures you see here, this fracture is mostly extra-articular with very undisplaced fracture line going terminally. So that can be treated successfully with the intramedullary nailing. While this fracture, you see there is a fracture line which is going inside the joint. There might be some displacement, but the fracture is definitely the articular simple one. While there may be extensive metaphyseal combination, but that will not hamper the process of intramedullary nailing. So nailing is good for extra-articular fractures of distal femur and those fractures which have minimal articular combination or the fracture pattern is simple. But there are some scenarios in which the nail alone cannot be sufficient. The points I will be discussing later. In osteoporotic fractures and in those fractures which have extensive combination in the metaphyseal part, the nail can be used as intramedullary stud, but it has to be combined with a plate. That means you need more stability in those fractures. The nail alone cannot provide that kind of stability because you see the nail will provide only 4 screws maximum in this part. The screws that are going through the nail holes are 4 in number. There might be recent more designs. It's better to supplement the nail with a plate in those scenarios in which you suspect that the stability may get compromised. So we'll be covering those topics in later slides. Now this is another scenario in which you have to avoid nail. So articular combination is definitely a contraindication for intramedullary nailing. So you see whenever we are going to place our nail, the nail is going to enter through this part. That means the terminal part of the Blumenstadt line, and that is going to make your fracture more complex. The nail will insert here, the hoop stresses will open up all these fracture lines, and you will face difficulty in fixation of these components because these components will need additional plate or screws in different planes. So that process may get compromised if you have already placed a nail. So articular combination is one contraindication where the nailing should be avoided. Now first step is to position the patient. So the nail has to be performed in a supine position. You can use a translucent angled support for the knee joint, which brings the knee joint in 30 to 40 degree flexion, or you can use a bolster also. By that you will be able to bring the terminal part of the trochlea directly underneath the patellar tendon, because ultimately you have to insert your guide pin through the slit you have made in the patellar tendon, or you can retract the patellar tendon medially. So this is a position that you need for distal femur nailing. Now the second step is to assess the fracture. You have to see whether the fracture is reduced or you need to do additional maneuvers. If you are not successful in the close reduction part or the fracture is displaced, definitely you have to choose the open reduction. By open reduction, you can directly visualize the fracture reduction and then pass the nail under your direct vision so that the nail passage does not hamper your fracture reduction. So in displaced articular fractures, you definitely want to go for an open reduction. The lateral parapatellar approach is usually sufficient for exposure of the condylar reduction. So if we are opening the joint, it's better to perform the lateral parapatellar orthotomy, and you'll be able to retract the patella medially, and that will bring the terminal part of the Blumenstadt line, or you can say the terminal part of the trochlea, under your direct vision, and it is actually the part where you make the entry point. And if you have already reduced the fracture or it was an undisplaced fracture, what you can do, you can simply use multiple K-wires to secure the reduction first, and then make an entry directly over the patellar tendon. So first thing is to secure the reduction. You have to decide whether you want to go for open or closed. So when the fracture is already reduced, you make an entry point either by retracting the patellar tendon medially or directly making a slit over the patellar tendon. So you see this white part is the terminal part of the Blumenstadt line, or you can say the terminal part of the trochlea. This terminal part or terminal part of the trochlea. We have to see the condyles area, whether they are comminuted or not. Minor articular comminution in the notch part is not a contraindication for nailing. You have to see what is the fracture pattern of the condyles. If the condyles are too large blocks, you can definitely go for nailing. So here also there is a small fragment. We should not be worried about that because remaining part of the condyles are still intact. So here the fracture was a simple one, and what we did, we made an entry here by slitting the patellar tendon, and you see my finger is there and I am able to palpate the terminal part of the trochlea, and also I will be able to feel whether there is any articular step or not. Minor articular steps can be corrected by simply positioning of the clamps in anterior or posterior direction. Usually the condyles tend to have anterior opening, and by using a clamp anteriorly we'll be able to compress that opening. Like here also you see we have tried to compress the condyles using a clamp. The reduction appears to be satisfactory in AP view as well as lateral view. The condyles are perfectly overlapping and are almost parallel, and we have used a sharp clamp anteriorly so that will prevent any further displacement, and we have placed multiple extra K-wires for securing the reduction. That is our step number 4. So you see the K-wires have to be placed in such a manner that they do not hinder your nailing process, because ultimately the nail has to go in the central part. You see this is the terminal part of the Blumenstadt line, or you can say the terminal part of the trochlea, or you can say the junction between the two. So that is the actual entry point, and the K-wires have to avoid that particular area, because this area, the longitudinal path in direction of the intramedullary canal, is the area for the nail insertion. The K-wires preferably should be placed in the posterior half, because that area is not going to be occupied by the nail. Or you can place some wires in the posterior part of the Blumenstadt line. That will also not hinder your nailing process. So here the same thing was done. Now once you are done with the reduction part, that means you have secured the reduction with multiple K-wires, and the K-wires I tend to use are 2.5 mm K-wires. These are really thick and good for reduction of the major condylar blocks, that means in distal femur. So here the same thing was done. Now after securing the reduction, we have to proceed for guide pin insertion. Now you see here we have tried to palpate the terminal part of the trochlea, or even say the terminal part of the Blumenstadt line, and centralmost part of that area is the entry point. You have to check that in AP and lateral view. It has to be directed perfectly parallel towards the intramedullary canal. You see here it is going to direct towards the intramedullary canal, and it is in the terminal part of the Blumenstadt line. Now sometimes this AP view is not clear because the hip is flexed to 30 to 40 degree. So for better assessment of the AP view, what you can do, you can simply tilt the C-arm in direction of hip flexion. So that will tell you the exact true AP view of distal femur. So it is not clearly visible here. The joint space of the condyles is kind of obscured, but when we tilt the C-arm, we get a better profile of this view. So sometimes when your implant or K-wires are hindering this terminal part in AP view, here it is not happening. But if it is happening, what you can simply do, you can simply tilt the C-arm towards the direction of hip flexion. That will show you the true AP view, and you'll be able to better appreciate the top part of this entry area that we have discussed. Now guide pin insertion direction has to be correct, because ultimately what you are going to do, you are actually going to create a small track in this zone that will guide the nail insertion. So if you have not made this entry perfectly central and perfectly in line with the canal, ultimately the fracture may tend to displace according to the direction of wrong track being created. So the guide wire has to follow the path of the intramedullary canal. So here that has been done. If this part is comminuted, then you need not to worry. Just focus on the terminal part. This track has to be perfectly created. Don't worry about the comminuted part. Some deviation of wire can occur in comminuted part, but it has to be perfectly aligned in the terminal part, that means near the condyles. The next step is the entry zone reaming. So you see the entry reamer is actually a large one, and sometimes this large entry reamer can displace your fracture. So what you can do, you can first use a smaller reamer size that might not be conventionally used, but you can use that to make a smaller entry hole, and that smaller entry hole can later be converted into a larger one with the entry side reamer that is provided by the manufacturer. And whenever you are doing all these things, you have to ensure that the clamps are correctly placed, they are not loose, because if they are loose, your fracture may displace. So before starting the reaming, just ensure that everything is perfectly reduced and clamped. Once you have created the entry side reaming track, you have to insert the long guide wire. You have to remove the guide pin that you have inserted earlier, then you can pass the long guide wire. We tend to use this finger reduction tool for passage of the long guide wire. You see, this finger reduction tool has a curve ahead in this part, and this curve actually guides the guide wire in the direction we want. So here we are able to push this finger reduction tool inside the proximal fragment, and then we passed the guide wire. Now here you see, this was the actual track of entry side reaming that we have created. But when we tried to mobilize this finger reduction tool just to get the direction of this proximal fragment, like here, the whole condylar block has moved in valgus. That means this track is the track that ultimately the nail will take. So it has to be perfectly central in the terminal part, and it has to follow the path of the intramedullary canal of the distal fragment, not the proximal fragment, because ultimately the proximal fragment will align itself with the distal fragment when the nail is inserted. So you have to follow the path of medullary canal of the distal fragment. Like here you see, we are following the path of the distal fragment, we are not following the path of the proximal fragment. You have to be careful whenever you are doing this, right? So the guide wire has been inserted, but you see, we have not secured the metaphysio-diaphyseal reduction yet. It is still displaced, but you need not to worry about that, because that is going to be covered in the next coming steps. So at this point, you have to see what is the direction of displacement of metaphysio-diaphyseal region. You see, the nail will ultimately take this path and this path in the proximal fragment, and the fracture will have tendency to displace in valgus. So these are the potential sites where you can actually use the polar devices. You can use a thick 2.5 mm K wire, or you can use a Steinmann pin, or you can use a polar screw also, but I tend to avoid polar screws in this part because of the risk of stress risers. Sometimes there is a splinter and iatrogenic fracture after placement of the polar screw, especially in the comminuted fractures, because often there are secondary fracture lines which will tend to displace the moment we tighten the polar screw. So usage of polar devices in form of Steinmann pin or thick K wire, 2.5 mm K wire, can definitely be an option. So we are now sure that a polar device can be placed here and here when we are directing the nail. The polar devices has to be placed in that zone where we don't want the nail to go. So we don't want the nail to go in this part, because that is going to angulate your fracture, and we don't want the nail to go in this part because that will also tend to angulate the fracture. But here this part is completed, so it will be difficult to place a polar device here, but here a polar device can definitely be placed because this fragment is intact, and we need not to worry about the alignment of the intermediate fragments, that means the comminuted fragments, if they are completely separated from the distal part, because ultimately they have to heal with the secondary stability, that means callus formation. Anatomical reduction is not the aim. Anatomical alignment, or you can call it functional alignment, is the aim when we are planning for the intramedullary nailing. So the shaft alignment with the distal part should be perfect, and we need not to worry about the comminuted fragments. So we have now decided that we will be placing our polar device here in our later steps. Now when we gave traction, we were able to get this alignment. So again, I told you we have to see the alignment of shaft with the terminal part, or you can say the articular part or the condylar part. We need not to be worried about this. So here the alignment appears to be satisfactory. The terminal part of the condyles is almost in slight valgus, that is normally there in the distal femur. And while giving this traction, we started the reaming of the diaphysis. So reaming here, if it is going in abnormal track, will not be an issue. You have to be central in the diaphysis. That is the only issue that needs to be addressed. The combination here is not the problem. You have to be central in the terminal, or you can say the condyle part, and you have to be central in the diaphyseal part. So the reaming has been done, and you see these small fragments, they are actually completely free. During the process of reaming, they are displacing, but again we need not to worry about that because they are actually the comminuted fragments which need not to be anatomically reduced. You have to secure the alignment of diaphysis with the metaphysis. So once the reaming has been done, you can then check the nail length that you'll require, but when you are doing so, you have to ensure that the fracture site length is perfect. So here you see we have some overriding. So the actual nail length will be slightly larger than we have anticipated. So that has to be taken in mind whenever we are deciding the length of the nail. The diameter will obviously be decided by the chatter that you are getting during the process of reaming, but the terminal part of the nail has to be just above the LT. That means here, somewhere here. You should not cross the intertrochanteric line. You should be just ahead of the lesser trochanter. If we go through the evidence suggests that the nail should never end in the diaphysis part, because if it is ending in the diaphysis part, it is going to create stress sizes. So we have to be ahead of the LT, because at the level of LT, we are having the diaphysio-metaphyseal junction. Now you see we have placed a thick 2.5 mm K-wire in this part where we don't want the nail to go. And the nail will ultimately take the path here in this area, and the displacement of the fracture in valgus direction will be prevented. Now additional thing that you need to address here is the shortening. Now here you see this part is actually shortened. Either we can give more traction, that will address the issue, but in case of young patients with bulky muscles, often reduction of this shortening is difficult. There are several maneuvers that can be used. You can pass a thick Steinmann pin or a Cocker's forceps intrafocally inside the fracture and then lever out the proximal fragment away from the distal fragment. That will tend to push the displacing fragment downwards, and you'll be able to achieve the length. Again, I told you the purpose of this maneuver is not the reduction of the comminuted fragment. It is only to secure the alignment and the length. And the moment you are getting the perfect length, just insert the nail with gentle tap or hammer. The moment the nail has gained hold inside the intramedullary canal, it is unlikely that the fracture length will tend to displace, but again in some unstable fracture it can still happen. So it's better to secure the alignment like this throughout the process of proximal and distal locking that will be covered in the coming steps. So the nail has now been inserted. Now whenever you are deciding about the reduction maneuvers, it's better to look at the CT. In articular fractures, we always get a CT done so that a better surgical planning can be done. So here you see this fragment was getting shortened in this particular direction, and you see there is some space here in the proximal fragment which can be used for placement of a device like Cocker's forceps or a Steinmann pin for pushing this fragment distally. So this fragment will act like a fulcrum and will be able to gain proper length. So same thing was done. We were able to push this fragment downwards while taking the support from the proximal fragment void here. So the Cocker here is actually gaining hold in this particular area, and that is actually helping in gaining the length at the fracture site. You can use other maneuvers also, like you can use a Steinmann pin and try to joystick this fragment distally, or you can use a femoral distractor also. So there are multiple methods that can be used. So the only purpose is to gain length when the nail has been inserted. Now the polar pin that we have placed here is functioning well, and the nail is not going in the path of least resistance that was here. Otherwise the fracture would have angulated in this direction. So now the alignment of this proximal part and this terminal part is satisfactory. We are not worried about this intermediate comminuted zone that was actually displacing, as we saw in the previous slide. Here you see during the process of framing, it was actually displacing. See, the displacement is happening here. So this fragment is unstable. We are not worried about that. That is going to heal by the callus formation. Now the next step is distal locking. But before committing to distal locking, you have to ensure that you have inserted the nail perfectly inside the articular surface or not, because the AP view can often be misleading. You see here we are thinking that the nail has gone quite inside, but when we check the lateral view, we are actually just ahead of the articular margin. You see this Blumenstadt line. This is the Blumenstadt line that is actually the topmost part of the intercondylar notch, and this smoothly curved line is the articular extent of the trochlea, and this was the area of our nail insertion. So you have to see the junction of your zig insertion and this dip inside the nail. So the nail end is here. So this end should be above this faint line of the trochlea and should be above the terminal part of the Blumenstadt line. If it is ending below the level of these faint lines, that means your nail is inside the joint. So you have to ensure that it has passed these lines whenever you are committing for distal fixation. And the proximal part, you have to ensure that the terminal part should be just above the level of LT, because here the canal is spacious, but here the canal is not spacious. But here in the diaphysis, the canal is not spacious and it can result in stress riser formation. So to avoid stress riser, you have to place the nail in an area where the canal is spacious. Now we have started a process of distal locking. You see, these are threaded screws. These are not bolts. They are getting engaged inside the nail holes. So 4 screw options are available in the nails that we are using, but you can use the other nails also, which are providing more screw options. More screws passing through the nail means more stability. Now we have inserted the other screws. So these screws are actually in different planes. 2 screws are medial lateral, while 1 screw is from the anterolateral and directing towards the posteromedial, while this screw is from the anteromedial and directed towards the posterolateral. Now the next step is proximal locking. Now before committing to the proximal locking, again check the length. The length should be perfect, because if the nail length is not perfect, you are bound to have some shortening of the limb. That might not be significant, but you have to avoid that. You can place either of the 2 screws first, but preferably the screws should be in 2 different planes, just to add more stability. So we have used 1 lateral to medial screw and 1 anterior to posterior screw. Now you see, earlier there was overriding here. There was some shortening. But I told you this fragment is unstable. So while this fragment can still displace, but we should not be getting any shortening. So you see what happened once we removed this cocker forceps, which was actually helping us in gaining the length. You see, even after removing, while it is displacing, but we are not getting the overriding like this. Here there was overriding, while here there's only the translation. So everything seems to be fine now. So the fracture length is fine and the alignment of the shaft part with the condyle part is satisfactory. Again, we are not bothered about this comminuted fragment. Now I told you there are 4 locking screw options in the nail. But what you can do, you can have other windows available for placement of extra screws. You see, we have zone here which is available for screw placement, and we have a zone here also that is available for screw placement. So whenever you are placing your screws, you can't place the screws in this posterior part, because that part is actually the part of the intercondylar notch. The Blumenstadt line is the roof of the intercondylar notch, while the part which is posterior to it is the area where we have the cruciate ligaments. So we do not want to place screws in this zone to avoid injury to the ligaments. Your screws should be above the Blumenstadt line in the posterior half and should be above the level of trochlea in the anterior half. So you see this faint line, again it is trochlea, and our nail, after removing the zig, we are now sure that the nail is quite above the level of trochlea. So it's not going to create the knee joint pain when the patient does knee movements. So the nail is not proud. So here you see we have used the other spaces that were available for screw placement. We have placed 1 extra lateral screw, 1 extra medial screw, just to add more stability to the condylar block. Now here you see in this lateral view, the extra screws have been placed, but this is an optional step. You can avoid this when the fracture is extra articular or is quite simple, but whenever you have the displaced condylar fracture, it's better to place extra screws, avoiding the area which has been occupied with the nail. Now the last part is the end cap insertion, because often when these patients have knee pain, they have tendency to get the implant removed. And during the implant removal, if this area is covered with bone, you will have difficulty in removal of the implant. So it's better to place an end cap in the terminal part, and that can be removed when the nail removal has been planned, and then the zig can be attached and the nail can be removed easily. So the most common complication after distal femur nail is the chronic knee pain. And you see, the chronic knee pain cause is mostly the proud nail. This terminal part of the nail is coming out here, and whenever this is coming out here, ultimately when the knee is flexed more than 90 degrees, it is going to hit the patella. So that's why the patient will have painful knee movements in the terminal flexion. Here you see the surgeon actually trusted the AP view. In AP view, he thought that the nail is inserted well, but when everything was done, he had removed the zig. He saw that the nail was slightly proud. You see there is articular cartilage here, and the nail is slightly proud of it. So actually he has invited the chronic knee pain for the patient. So that thing should be avoided. You should better insert the nail more, but making it proud is not a good thing. So a lateral view is a must whenever you are committing to distal fixation. And also it's better to check in C-arm what is the junction of the zig and the nail. You can go and check the C-arm closely and see what is the junction. So here is, you see the junction is quite clearly visible. So that is the ultimate end point of the nail, and it is above the level of trochlea. So you have to ensure that the nail length is correct, it is not proud. So this was the post-op radiograph of this patient. You see, while the nail appears to be inserted deep in the AP view, it is just above the level of trochlea. It is not too deep. So AP view can be misleading when we are confirming whether the terminal part is coming inside the joint or not. But when we are inserting the nail through the parapatellar arthrotomy on the lateral side, in case we are going for open reduction, then definitely it is in our direct vision. So that should not be a problem. But when we are going through the patellar tendon area, it is definitely going to be a problem, and you have to ensure that the lateral view is perfect. The nail has sunk properly. And here you see in this x-ray, again this fragment has translated, but that's not an issue because ultimately the spike levels, the spike here and a cavity here, they are actually matching. That means the length is correct. Now some of you might argue whether to go for nailing or plating. So you see, the nailing and plating both can give you favorable outcomes when we use them wisely. When we respect the principles of each device, we are going to get favorable outcomes. Like here you see, this committed fracture with minor extension into the joint was treated with intramedullary nailing and it healed satisfactorily. There is huge callus formation here, and this fracture, the articular extension is there and there is comminution in the metaphyseal part, and this was treated with plating. So it is also healing with callus formation. But what we have done, we have tried to gain a long working length. We have avoided placement of high density screws in the zone. We have used a long plate and tried to maintain 50% screw density in the diaphysis part and 0 screw density in the fracture area. So that is actually the principle we are following. So that is going to bring the outcome in a favorable manner. So there should not be any arguments regarding whether the nail is good or the plate is good. Both are good when they are used in a wise manner. But since we have discussed the nail has biomechanical advantages, there are some pitfalls also. So while you see in the plate, we have the screws perfectly locked on the plate. That means they are not going to migrate in the medial or lateral direction, and also they are not going to rotate easily unless we use a strong force with a screwdriver. But here in the nail, these screws are actually engaging inside the nail. They are not getting locked. They can still rotate. So the anchorage of the screws is less in case of IM nailing screws. And also the screws here are part of a broad surface plate. But here screws, they are actually independent in the peripheral part. So ultimately the anchorage, that means the ability to hold the condyles at the area of insertion, is limited in case of the nailing screws. Individual nail screw might not hold the bone well as compared to a locking plate screw, and that is the issue in case of osteoporotic fractures. So in case of osteoporotic fractures, the nail alone may not be sufficient. You have to support the condyles with some form of plate fixation also. You can just imagine in some osteoporotic patients, you can place a screw even without drilling by just pushing it. So that thing can happen with the nail screws also. So the hold of the screws in the peripheral part can be weak in case of osteoporotic patients. So the condyles can still displace in this zone or in this zone. So we need extra stability in those scenarios. The nail alone is not going to be sufficient. The nail alone will be sufficient only in case of young healthy bone. And I've told you, these screws are engaging inside the nail. They are not getting locked inside the nail. You can still rotate it more till the point it goes somewhere here. So that is not the locked screw, that is actually the engaging screw. So the nail alone will not be sufficient for the osteoporotic fracture. And also in some unstable injury, we need a buttress effect. So buttress effect cannot be provided by the nail. The only stability that the nail is going to give is the area of the screw and the nail junction. The screw cannot deviate in varus or valgus direction or in flexion or extension because of the multiplanar stability. But the condylar hold in the terminal part of the screws may not be good, and the fractures which have unstable pattern, they will have tendency to displace because of the forces in the peripheral part, and those fractures should better be supplemented with a plate whenever we want the buttress effect. So the nail plate combination is the one which has been used for osteoporotic fractures. So in that, you can either place a plate first to provide the buttress effect of the plate, and then place few screws that are unicortical, and then pass the nail. And once the nail has been passed, you can just push the screws so they gain hold on the opposite side cortex. I will try to place a presentation on the nail plate combination for distal femur fractures as well. So I hope this presentation regarding the intra-articular fractures fixation with distal femur nail will be helpful for you in your surgical planning. And if you have any queries, you can just put those in comments. Thank you.